For the first time, an optometry session is conducted in Drishti. We were really overwhelmed by the response we got from the optometrists all over the state. I welcome you all to this session.
We start with the first session. I request Dr. Padmaja Krishnan. She is the Department Head of Ophthalmology at MES Medical College to give her first talk on objective refraction.
Thank you so much, Soumya. Thank you for having me to speak at this session. And good morning and welcome everybody. Like I was telling Susmi this morning and before I met Dr. Aditya, from my vantage point, all of you look so young, so fresh, and I had a doubt whether you were actually fully trained optometrists or you were still students of optometry. My topic, which I'm going to deliver without a PowerPoint and without slides, is to do with what all of you know, what all of you were trained to do. And many of the things I say will be well known to you and probably seem superfluous. But from my point of view, and of course when I started working as an ophthalmologist, refraction was the bread and butter of our lives. When we did our practice, I have done umpteen. It's changed over the years. Ophthalmologists increasingly depend on you for giving a proper glass prescription. But in my day, I checked the vision, I tried the glass, I put the drops, I did the refraction, and I called for the PMT and prescribed. And as things changed over the years, even as I was practicing, I know where the changes occurred, and I know that some of those changes were good for me because it took away a lot of the burden of what I had to do. But along with that, I know that I had a lot of problems when refraction was given over to somebody else who did all the things that I was so used to doing. So my talk to you today is ultimately you are the people who will try the glass. No longer in our cubicles do we have the wherewithal to check vision. So most of our cubicles have the slit lamp, have other equipment with which we examine eyes, but we no longer have the Snellen, we no longer have the trial fluid. So we depend on it. And I know that certain problems that have crept into glass prescription and the checking of vision have to do partly with our having delegated all of this to you. What do I mean by this? Manual refraction, till you master it, is a bore. So manual refraction, I don't know. Can I ask you, how many of you, other than the AR, actually do a streak retinoscopy? So, am I right in thinking that manual retinoscopy as a skill is no longer as common as it used to be? There was no AR when I started training. And let me give you an anecdote. Many years ago, when ARs came into all optical shops, not into the hospitals, I had a patient for whom I used to routinely prescribe presbyopia glasses. And then he came to me saying, ഞാൻ കണ്ണട മാറ്റാനായിട്ട് ആലോചിച്ചപ്പോൾ അതിലെ നടക്കുമ്പോൾ കമ്പ്യൂട്ടറൈസ്ഡ് ടെസ്റ്റിംഗ് എന്ന് കണ്ടു. അപ്പോൾ ഞാൻ വിചാരിച്ചു കമ്പ്യൂട്ടർ ആണെങ്കിൽ നന്നാവില്ല. അപ്പോൾ ഞാൻ അവിടെ പോയിട്ട് കമ്പ്യൂട്ടർ ടെസ്റ്റ് ചെയ്യാൻ പറഞ്ഞു, എന്നിട്ട് കണ്ണട തരാൻ പറഞ്ഞു. ബട്ട് അത് കഴിഞ്ഞിട്ട് അത് അയാൾ നിങ്ങൾ ചെയ്യണ മാതിരി ചില്ല് വെച്ച് നോക്കിയിട്ട് ഇതോ നന്നാ അതോ നന്നാന്ന് ചോദിക്കുന്നു. അപ്പം പിന്നെ കമ്പ്യൂട്ടറിൻ്റെ കമ്പ്യൂട്ടർ തന്നെ കാശ് വെറുതെ വാങ്ങിയതല്ലേ. അപ്പം ഞാൻ തീരുമാനിച്ചു തട്ടിപ്പാണ്. കണ്ണട വെച്ച് നോക്കുകയാണെങ്കിൽ യു ആർ ബെറ്റർ, ഐ എം ഷുവർ ദാൻ ദാറ്റ്. So you please check and prescribe the glasses. There was nothing wrong with the prescription. So in those days, before computers became, of course all along we've always believed the computer is the ultimate. But we know in so many, I've been going to sessions where they have been telling us technology is great, but the man behind the machine just pours out data. There's this popular saying, rubbish in, rubbish out. So if something goes wrong in your settings, if something goes wrong in the working of that machine, you have nothing to go back to. That report that you have may not be right. So when I talk of objective refraction, like all of you know, it is you estimating the refractive power of the eye. It is you and us trying to find out the lens system of the eye how is it focusing the light? I wanted to come to a point, focus on the retina, but maybe that's not what's happening. Either there's no point focus, it's a line, it's a blur, it's a circle. And I'm trying to bring back that image to where it is. So, as you all know, the principle of retinoscopy is I get the light into the eye, the light then retraverses the path and it comes out either divergent, convergent, or with very little divergence, which we consider parallel. And then, if I'm doing a manual retinoscopy, I artificially put in lenses to focus that light where I am sitting. So that at the moment of what I call neutralization, the whole pupil, I'm sitting where the light focuses, the whole pupil becomes full of light, bright. Or if I'm slightly off center, the whole pupil becomes black. Now, those points are very well defined. They're very, once you know what you're talking about, you pick it up so easily. But the initial phase, I tried to learn swimming in my old age, and I know how difficult I found it. So these are skills that you got to pick up now and practice regularly, and then it is nothing. It's as simple as anything else. Of course, people are going to talk to you about conditions where it may not be so easy doing a manual retinoscopy. But where are the times I really need an accurate refractive estimation of the refractive error? It's always in children. It's in children unless I paralyze their accommodation and check. I will never know what kind of error they have. I even have my young undergraduate medical students come to me every 6 months saying, Madam, ende myopia koodikondirikka, and it's a 0.25 increase. And you dilate and they're all emmetropic. The reason is they're nervous, they're anxious, they accommodate, and even for me who's a hypermetro, I add a minus 0.25, things seem clearer. So I need to know whether there is an actual refractive change in these people. And that is where I depend on you. Now I said earlier, the problem with delegating that I have seen is that you people also, now you told me most of you are doing AR. I've had people where the manual retinoscopy, the subjective acceptance, and the AR values have been slightly out. And then when I ask the optometrist, they will say, Adalla madam, ഞങ്ങൾ adjust ചെയ്ത് എഴുതിയത്. And the first time I heard this, I wanted to ask, where did you do this adjustment? So what do? They do a manual retinoscopy. They're not confident about their values. They do an AR and then alter the manual retinoscopy reading to match the AR. Now that to me can be so wrong when you do it in a child. So my request to all of you is learn to do a proper manual refraction. It is very, very useful, or has become popular over the years. You can do a cycloplegic automated refraction. That might give you. The other problem with the computer, of course, it gives you these cylindrical values, it gives you axis, but you need to know what makes the patient comfortable. I have no way of coming back and checking your prescription. And this again, I've had so many times. I've had this patient who's been wearing a cylinder at 90 all his life. And then both the AR and your manual retinoscopy, which you adjusted or didn't adjust, suggests 75. And you put it at 75 and the patient says, I see really well now. But he was wearing it at 90. Now vision is not all about the image. Vision is the way my brain interprets the image. Whether I see you the same as they see you, I don't. Whether the green I see is the green they see, I do not know. All I know is that from my life, all from my birth, I know that this shape corresponds to what I see there corresponds to something. Let me also say another thing. I've said this so many times, but it's made such an impression on me that I will say it again. I had this patient who was about 30 diopters of myopia. She had not been seeing well almost all her life. But I don't know why, into her 40s, she came to me saying, of course, I knew with that, level it was not very easy. I refracted, vision less than 660. And I told her there were degenerative changes, it's going to be difficult. Then she said, doctor she came back for a PMT. And of course, I don't have -30 on my trial frame. I started with a -6. And somewhere along 7 or 8, she said, Nirtu, doctor avada nirtu. Inikippa doctor nannayittu kaanade enikku venu. When I realized that all of us have a horizon, she has never seen in the distance, nor is she asking to see in the distance. She is asking for the vision that will help her to see around her, which she didn't have now. That was her only request. Now, whether it was she never, obviously she must have been happy with her glasses or she went to somebody else. She never came back to me. Appa I said, no, let me try again, whether you will see. She said, എനിക്ക് അതൊന്നും കാണണ്ട, എനിക്കിപ്പോൾ കാണുന്നത് ധാരാളം മതി. Doctor ഇപ്പോൾ അതിലുള്ളത് എനിക്ക് എഴുതി തരും. I don't want it. So when we had this famous textbook by Duke Elder, and the first sentence was, it was the art and the science of refraction. And that is an idea that I love to put across, that it is not physics, it is not maths. Physics and maths are the basis behind estimation. But the final prescription that you give must be tailored to the patient. Change the axis like has been done so many times. Patients come back saying, പഴയ കണ്ണട വെച്ചിട്ട് എനിക്ക് ഇങ്ങനെ പിടിച്ചാൽ കണ്ടിരുന്നു, ഇപ്പം എനിക്ക് ഒന്നും കാണുന്നില്ല, ഐ എം സോ അൺഹാപ്പി, ഐ കാണ്ട്. ഇത് കുറച്ച് നേരം വെക്കുമ്പോഴത്തേക്കും everything seems strange. Because they were interpreting an image that may have been slightly tilted, whatever, but their brains had corrected it. They could see perfectly. In the refraction room on the Snellen, ഇതല്ലേ കുറച്ചും കൂടി നന്നാന്ന് ചോദിക്കുമായിരുന്നു. I've had all kinds of optometrists. I've seen a senior optometrist say, they'll read, 205 whatever, and then he'll say, he will give 2 of the numbers. And these are things I know you do to make us happy, because you want to get that 6-6 with some correction, which impresses us that you have done a good job. But I know that everyone may not improve to 6-6. And I know that it's the patient who should talk to you. It's the patient who must say, I am comfortable. Of course, there was a time when we didn't do binocular balancing as regularly. We are very, very happy with optometrists now, because they've taken such a burden off our shoulders. They have learned to do it properly. It's only the odd times when you have difficulty. That difficulty might be there across the board, provided you know what you're doing. So my request to you is, learn to do a manual refraction. Never ever suggest to a patient, idalle bheda. Let the patient tell you, idana bheda. Never ever give a hint to read, IQ. Never do that. Kaanindo illiyo. And of course, very many years ago when I was in the UK, again, in those days, optometry was coming up. But we did our own refractions, and refraction was part of the exams as well. So after you put in your final prescription, I don't know whether you still do it, we used to add or subtract a 0.25, go to the line just above the one they read, go to a letter on that line and say, is it sharper, brighter, clearer? Are the edges sharper? Is the black on the white clearer with the plus or the minus? Now all these are little things which you might have been taught, but there's a big difference between theory and practice. And unless you do it for yourselves, unless you put that little extra effort to believe, I'll tell you something, because in those days prescribing glasses, like all my senior ophthalmologists were, was one of our major jobs. And in fact, when I chose ophthalmology as a subject, again my mother said, അപ്പോൾ നാളെ തൊട്ട് ഇതോ നന്ന് അതോ നന്ന് ഇതോ നന്ന് അതോ നന്ന് എന്ന് പറഞ്ഞിരിക്കാൻ പോവുകയല്ലേ എന്നായിരുന്നു എൻ്റെ അമ്മയുടെ ചോദ്യം. But a properly prescribed pair of glasses is such a thrill. I've had senior of a doctor who came to me, who had an early cataract, was advised cataract surgery. His only complaint was he couldn't see the PowerPoint. And again, when I prescribed his glass, he said, oh, he knew me as a friend. ഇത്ര വലിയ ഓഫ്തൽമോളജിസ്റ്റ് ആണ് അറിഞ്ഞില്ല. അപ്പോൾ I said, സാറേ, ഞാൻ തുടക്കം തുടക്കമുതലേ ചെയ്യണ പണിയാണ്. And all I did was order. Oh, it is so wonderful. I don't want any cataract. I can see that is good enough. So we do perfect cataract surgery. Okay. After that, when if they need glasses and that glass is wrong, all that we have done will come to naught. So believe me, you're very, very important partners with us in management of refractive errors. And I want you to believe that you are not junior partners, you're not inferior partners. When it comes to seeing clearly, we depend on you. You are our friends in arms, and we would like you to take as much interest in the vision and the prescription of the patient as we do. And with that, I stop and hand over to you.
Such a wonderful talk highlighting the importance of objective refraction. Thank you. So, the take-home message is never to rely on the instruments only for your refraction. You need to master the skills on your own, and that you have to decide how to start, when to start, and keep practicing till you learn everything. And Madam has already said the importance of subjective refraction. So we go on to the next topic, the subjective refraction.
Now I invite Dr. Aditya Goyal, the department head of Shankara Hospital, Bangalore. He is a well-known figure in the field of optometry. He was instrumental in establishing the College of Optometry in Chennai, Bangalore and Ludhiana. He is the mentor of optometrists in the Shankara Eye Group. He is the alumni of the elite group of optometry. We welcome you, sir.
Good morning, everyone. Wonderful to be in Kerala. Love the place. And like what Padmaja just mentioned, objective refraction, that is with retinoscope, not with automated refractor. I think that's the best thing you can do, because that is where you get to know what is exactly happening within the eye, and automated refraction does not even tell you what is happening within the eye. 35 odd years of my life, I've used autorefractor only once in my life when I was doing my exam in US. Apart from that, I've always worked with a retinoscope, and it's a fantastic tool. So when Dr. Padmaja was talking, I remembered a long back there was a debate in Shankara Netralaya on autorefractor versus retinoscope. I made a statement, I made only one statement. Autorefractor is a wonderful tool in the hands of an intelligent optometrist or ophthalmologist, and a disaster in the hands of an idiot. And that's exactly what I personally believe. Autorefractor is not a bad tool at all, but then you should know how to use it, and most importantly, how to refine your prescription subjectively. Because if you do not refine it properly, that is exactly what your patient is going to wear over a period of time. So you should have a perfectly refined prescription for a patient, for prescription. So basically, when we are talking of subjective refraction, you're looking at two things: monocular subjective and binocular subjective. So all of you have been doing a lot of monocular subjective. I'll lay more emphasis on binocular balancing and binocular subjective refraction. But all the same, let me go through a little bit of monocular subjective, where we are looking at the monocular endpoints, spherical endpoint, then you look at the cylindrical power using a JCC, refine it, and finding the spherical and the cylindrical endpoint. That is where your monocular subjective ends. Binocular subjective is most important because it is something like balancing both the eyes. Now, I want to know how many of you do binocular balancing? Nobody? When you do your subjective refraction, do you balance both the eyes? You don't. Okay. So I think that will be something important for you, because it is something like if you're wearing a shoe, one has a 4-inch heel and the other has no heel. Will you be able to walk properly? So that's exactly where binocular balancing is, where we are trying to balance the accommodation between the two eyes. Because monocularly you might have overstimulated one eye or relaxed the other eye, or anything could be happening. So it makes a lot of sense when we binocularly balance the both the eyes, the accommodation in both the eyes. So we are looking at balancing both the eyes and then refining the spherical power. There are certain miscellaneous tests which we will not go through. 15 minutes is not sufficient to go through all those tests. So these are some of the miscellaneous tests that we do. But let me quickly go through monocular subjective and then come to binocular balancing. Now, how many of you use Jackson's cross cylinder? Only one? Alright. It's a very important tool because that is what gives you a proper refinement of your axis and the power. Alright, so initially what we are doing is maximum plus to minimum minus for maximum visual acuity. So you occlude the fellow eye and then you start working on your objective value. You work only on the spherical first, wherein you keep on adding the plus power or the minus power till the time your patient is just able to see the best corrected line. So let us say he has 660, you keep adding plus power or minus power depending upon what your objective value is in sphere alone, and then at one particular time it will not improve any further. That is the best monocular subjective refraction that you can do. Now what we want to do is maximum plus or minimum minus for the best visual acuity. Why do we do that? Maximum plus or minimum minus, because if I start giving more minus, I'm going to stimulate accommodation, which today there's a lot of hoo-ha about myopia and myopia control and myopia progression. So that is exactly what is going to happen, because if you stimulate more accommodation, that much more myopia is going to be created, and your brain gets used to that. And after a few months, again the patient comes back to you, you again prescribe that higher myopia, and myopia keeps on progressing. So that is the reason why we like to give maximum plus, minimum minus for the best visual acuity. How many of you do diochrome? Again 1, 2, 3, okay. A lot many. Fine. So what do we do in diochrome? You have some letters in black color over red background or the green background. Now it is working on the principle of chromatic aberration. Okay? So if the patient, what is the question that you ask? Do you ask, are you seeing it clearer, or do you ask, are you seeing it better? I think we should ask which is better, because clearer starts stimulating accommodation. Okay? So against one background, either red or green, the patient sees something better. So if the red is better, then you keep on increasing minus power or reducing plus power. If the green is better, you increase plus power and reduce minus power. Okay? And where both are almost equal or one towards the green is better, just stop there, and that is your subjective spherical endpoint. Never ever do duochrome for cylinders. Duochrome is meant only for sphere and not for cylinder. Now this is a great tool, Jackson's cross cylinder, that we use, and you see the black lines and the red lines. Red line in this particular thing is for the minus power, and the black is for the plus power. So the first thing that we do with the Jackson's cross cylinder is refine the axis of cylinder, because power will come later, because if the axis is wrong, you're going to get a wrong power. So you have to refine the axis of cylinder. So whatever objective cylinder you got, have your axis placed, have your cylinder placed in the trial frame or the phoropter. Keep the handle of the Jackson's cross cylinder parallel to the axis, and flip it over. You show your patient two positions, one and then the second one. Whichever the patient feels is better. If you have a minus cylinder, move it towards the red. If you have a plus cylinder, move it towards the black. So move about 5 degrees towards red or black till the time your patient says both are equally clear. Then you go on to refining the power of the cylinder, where you put the lines of these, either the black or the red lines, parallel to the axis. Earlier you had the handle which was parallel to the axis, that was for the axis. Now for power refinement, have the marks which are parallel to the axis. And once they're parallel to the axis, let's say you have a minus cylinder in place. If the patient says he is better with the red lines which are parallel, increase the minus cylinder. If he says the black lines are better, then decrease the minus. Okay. Is that clear to everyone till now? Great. So once you have refined your sphere, you have refined your cylinder, your axis is perfect, your power is perfect, and your patient is possibly seeing 6/6, you feel that you have achieved the ultimate? No. That is where the role as optometrist comes in, and you have to binocularly refine the prescription. Like I told you, the accommodation, you're doing your monocular refraction. At that time, what can possibly happen is you might have overstimulated one eye, accommodation in one eye. You might have understimulated accommodation in one eye. So you have to balance both. Now, how do you go about balancing? The first thing you have to do is negative and positive relative accommodation. Now, what is negative and positive? Yeah, one more thing. These have to be done for phakic patients. Please do not try for aphakic or pseudophakic patients. It does not work for them. Secondly, the patient should have almost equal acuities in both the eyes, invariably 20/20 or 6/6 in both the eyes. Otherwise, if it is 6/60 in one eye and 6/6 in the other eye, don't bother about this. All these things don't work. Okay? So let's say your patient has 6/6 acuity in both the eyes. You do NRA PRA, which is negative and positive relative accommodation. What we are working towards that is we want to find out how much of accommodation with your prescription your patient is able to relax accommodation and how much of accommodation is stimulated. With the negative relative accommodation, we are relaxing, and with the positive relative accommodation, we are stimulating. Now, what do we do in this? It's a binocular test. The reason why it is binocular is that we are checking accommodation relative to a constant vergence effort. So we are keeping the target, your N8 size target, at 40 centimeters. So that is providing some amount of convergence to the patient. Keeping that convergence constant, you are changing your accommodation. So whatever your prescription for the patient has, binocularly add plus 0.25, and the instruction to the patient is, let me know when the target becomes blurred. Sustained blur. Sustained blur is when the patient is not able to clear with the maximum possible effort. So let me just make it clear to you. You have your subjective monocular, subjective refractions. Keep both eyes open. Give a target, N8 size target at 40 centimeters. Keep putting binocularly plus lenses, plus 0.25 in 0.25 steps. Keep on increasing and ask your patient when the what he's seeing is totally blurred and with the maximum effort he cannot make it clear. Now, can you tell me how much should be NRA? Any guesses? What should be normal NRA? Like I said, NRA is relaxing accommodation. We are working at 40 centimeters. So what should be normal NRA? No guesses? Ideally it should be 2.5 diopter plus 2.5 diopter, because 40 centimeters stimulates 2.5 diopters of accommodation, right? And when you have done a distance refraction, what is the end point of your distance refraction? Accommodation was totally relaxed. When your accommodation is fully relaxed for distance and you're checking the NRA at 40 centimeters, you should be stimulating 2.5 diopters of accommodation. So if I'm stimulating 2.5 diopters, how much can I relax? I should be relaxing only 2.5 diopters. I can't relax more than that. I can definitely relax less than 2.5 diopters. But once it is totally blurred, that means my accommodation is fully relaxed. Am I right? Okay, so if let us say you do your NRA and your value is +4, what does it mean to you? You have overstimulated accommodation. The patient had 4 diopters of accommodation. So what have you done? Either you have prescribed less plus or more minus. So in our hospital, we made it a kind of rule that every patient has to undergo NRA PRA. People used to make fun of me. My students used to call me, they had nicknamed me NRA PRA. But then today we have made it a kind of protocol where in our hospital, every patient undergoes NRA PRA, and we are able to find out how many patients we are overcorrecting. We usually don't undercorrect, but then overcorrection of myopia or undercorrection of hyperopia is clearly seen when we do this NRA. So once you have completed your NRA, you come back, 0.25, 0.5 down, come back to plano, and then increase minus. Minus is going to tell you that is PRA, that is going to tell you how much the patient can possibly stimulate. Now if you add both NRA and PRA, just the values, not the signs. Let us say NRA was 2.5 diopters and PRA is 6 diopters. What does it mean to you? The range of accommodation was 2.5 diopters plus 6 diopters, which is 8.5 diopters. So you are able to find out the patient's accommodation range. Is that clear to you, all of you? So you're supposed to do this NRA and PRA, and that gives you a proper understanding of accommodative status of your patient. Once you have achieved that, then take off your PRA values, go to NRA, take a patient to the distance vision drum. You remove your 40 centimeter near vision target, take the patient to distance vision drum. And once he's on the distance vision drum, he'll see nothing, because you have plus 2.5 diopters or so in front of his eyes. Reduce plus 0.25 binocularly till the time your patient is able to see 636. Okay, so you keep on reducing 0.25, 0.25, and at one particular time, your patient will be able to see 636. Now you put base up prism in one eye and base down prism, small amount of it, probably about 2 to 3 diopters or 4 diopters of prisms, basically to dissociate the two eyes. I want to check the accommodation in both the eyes. Now he is seeing 636, you have dissociated the two eyes, he will see one set of letters here and one set of letters here. Now your question to the patient is, which of the two is better? Let's say he says the one at the top is better, and you have those prisms in the right eye. What are you going to do? You're going to add plus 0.25 to that to make it blur. When the patient is seeing better, what does it mean? That he was stimulating more accommodation in that particular eye. I want to relax that accommodation. So please keep adding plus 0.25 diopters in the better eye till the time your patient says both are equally clear. Once your patient says both the eyes are equally clear, remove the prisms, make him fuse, and then reduce plus binocularly till the time your patient is able to see 6/6 perfectly with the least minus or the maximum plus. That will binocularly balance both the eyes. I'll tell you, very recently we had a case where we had prescribed, I think, minus 3.5 or something in one eye and minus 3.25 in the other eye. And the patient had diplopia, patient had a whole lot of problems. He had had some stroke, but then all the same he had diplopia with that. So we prescribed some prisms also, but the patient was not happy with those prisms. Then he came back again saying that he was not satisfied with that particular prescription. We did a binocular balance, and guess what we found? He had a 2.25, minus 2.25 in one eye and minus 2.5 in the other. And with that minus 3.5 and 3.25, we had prescribed a presbyopic addition also. We had prescribed plus 1 diopters of presbyopic addition. Now with the minus 2.25 and 2.5, he didn't require any presbyopic addition. He was able to see perfect 6/6 in 6, and he had no diplopia. So it is very, very important that we binocularly balance the prescription, and once it is binocularly balanced, prescribe it. Your patient will say that yes, I am not happy with this, initially, because you are prescribing more plus and less minus, but explain to the patient that it is necessary and what you have actually done, and all the patients will take it. Once you have done that, look at your duochrome. You could do a binocular duochrome by putting prisms in the eyes. You could balance both the eyes perfectly well and prescribe those glasses with full confidence, and no patient will be dissatisfied. And I think we will be able to control myopia considerably with proper prescriptions. We don't require those funny lenses and funny methods that we are talking of today. One more case I would like to tell you. I think I am running out of time, but just one case where this patient had come. He was in Bangalore. We have every second person is IT professional. So he had come, and then he had a -4 or something. And we did a refraction, and he was -5 or something at that time. Somehow that patient landed up with us in the binocular vision clinic, and when we did a NRA-PRA and all the tests, we found that it was high. We did a cycloplegic refraction, NRA-PRA and everything came down, but still it was high. We did atropinization. We don't usually do it, but then because of this particular case, we did atropinize him. And after that, can you believe what the power was? We had been prescribing him -4 or so. He was a hypero. Ultimately, he is happy today with +3 diopters of hyperopia. And we had made a myope out of him. So your subjective refraction is very, very important. Please let me know in case you have any questions. Thank you for your attention.
How much high minus power?
A lot of people who we are prescribing today, they actually do not require that much of myopic prescription.
Especially in today's pediatric age group, when you are over-minusing the children, they tend to have progressive myopias more often. So we have to have a minimum minus, always not undercorrect. Correct? Exactly. Appropriately. Undercorrection is not used nowadays for myopia. It has to be corrected appropriately. So either you have to remember that maximum plus and minimum minus. That is the right, which is minimum minus means the minus which is acceptable to the children appropriately. So
Something like with some power you have patient C6. If you give more minus, he'll say it is even better. So don't do that, because minification neurologically makes the things better for a human being. Thank you.
thanks a lot for the wonderful talk, sir. So we move on to the next session.
Now I invite Ms. Susmi Hamid. She is an optometrist from Girida Eye Hospital with keen interest in PSV.
And optometrist and in charge of PSV at Girida Eye Store. So today I'm going to speak about refraction in complex case. So the first topic is pediatric refraction. Pediatric itself is a complication, right? So what are the things we have to consider before starting the pediatric refraction? First of all, we should create a rapport with the child. You know, most of the children will not get along with the strangers, especially in the hospital environment. So make sure that they are comfortable with us. That's very important thing. And also we should record all the histories from the parents that include the ocular complaints, general health history, birth history, developmental history, and is there any history of seizures. That's very important. And we should record all this from the parents. And the examiner should be aware of all the possible factors at different age group and also about the metropization, and should know a good skill at retinoscopy. That's very important. So here the table shows the possible refractive errors at different age group. The first age group is less than 1 year. So a healthy neonate will be hyperopic, but in some cases, if the baby born preterm and not gone for any ROP laser, the refraction will be myopic. But from 3 to 5 years, we can see all type of refractive errors. But in adolescents, most of them will be ametropic and more myopes than the hyperopic. And astigmatism and isometria will be more common in all age groups. So what is ametropization? What is the importance of ametropization? Ametropization is a process in which the refractive error of the child going to reduce or the eye become emmetropic. And during the first age of the life, the emmetropization will be faster and gradually slow down and stop at the age of 4th year. And in adulthood, there will be more chance for myopic refraction. So what will happen if we fully correct a child during the emmetropization? That will interfere the normal visual functioning of the baby or the development of the visual function of the baby. And also moving further, there is a chance to develop more more refractive error in that child. So we don't have to fully correct a baby during the emmetropization. That's very important. So this table will give you an idea to how to correct different refractive errors at different age groups. The first age group is less than 1 year. So if here the baby has greater than 5 diopter of hypermetropia, we can undercorrect it up to 2 diopters for the emmetropization. But in the case of myopia, we can undercorrect up to 1.5 diopter. But astigmatism is not sensitive at this age because it will rapidly reduce during the emmetropization. So it's not sensitive. And if the age is greater than 1 year, if the child has greater than 3.5 diopter of hypermetropia, we can undercorrect up to 1 diopter. And in myopia also, if it's greater than 2 diopters, we can undercorrect up to 1 to 1.5 diopter of myopia. And in astigmatism also, we can undercorrect up to 1 diopters if it's more than 2.5 diopter. At the 4th year of the age, if it's the hypermetropia is greater than 2.5 diopter, we can give the full correction or can slightly reduce it up to 0.5 diopter. That will depend upon the visual acuity. It's 4 year, so we can that will depend on the visual acuity and symptom of the patient. And if the myopia is greater than 1 diopter, we can give a full correction or either a slight reduction. And in astigmatism, if it's greater than 1.5 diopter, we can either give the full correction or a slight initial reduction. That will depend on the visual acuity and symptom of the baby. And on the school-going ages, if it's if the hypermetropia is greater than 1.5 diopter, we should correct it according to the symptom of the child. And in myopia also, we can either give the full correction or a slight reduction. That will depend upon the symptoms and visual acuity of the child. Next, astigmatism also, we can correct it or initially reduce it depending on the visual acuity and symptom of the child. So what are the challenges we will face during a pediatric refraction? Of course, the child will have a wide range of accommodation, and also they will not be cooperative enough and do not fixate properly. So there will be difficulty in quantifying visual status of the baby. So here the commonly using charts which include the Cardiff acuity, Teller's acuity, Allen's pictures and Lea symbols. I think it's more commonly using, and OKD in infants. These are charts which is using in preschool children's. So as Sir said, cycloplegic refraction is very important, especially in children. We have to suggest cycloplegic refraction in all children, especially those who have hypermetropia or convergent squint, because a good amount of hypermetropia will be hidden under control of the ciliary muscle tone. So we have to suggest a cycloplegic refraction in every child, those who have hypermetropia and esotropia. In esotropia, here also the refractive or accommodative component will be we will get after the cycloplegic refraction in this condition. So in whatever the refraction it's cycloplegic refraction or objective refraction, try to use user-friendly things like lens tracks. In children, we can use the lens tracks because it will be user-friendly both for the examiner and also for the child. Because most of the children will not cooperate to wear the trial frame. So we should use user-friendly things while examining the child. So how to give the correction in a myopic child? We can give the full correction in a child. It's not always to undercorrect the myopia, but we can correct the myopia fully. That will depend upon the visual acuity and how much the myopia, how much power required to improve the visual acuity of the patient. Because it's very important the case of the patient has amblyopia. We have to give the full correction with a tonus reduction in these cases. And we also verify that whether it's overcorrected or not. So we can do the duochrome test. It's very must in myopia. And so what will happen if we overcorrect a myopia? When we overcorrect a myopia and the patient is prolongedly using the myopic correction, moving further, it will stimulate the accommodative convergence of the patient. So after few months or few years, there is a chance to develop esotropia or intermittent esotropia or esophoria in that patient. So the patient will be very symptomatic, especially the children. They have very accommodative ability. So if we overcorrect the myopia, that will again stimulate the accommodation of the patient, hence the accommodative convergence. That will that will make ESO deviation or convergence further in their development stages. So in these conditions, we have to undercorrect the myopia of the patients. Or if the myopia is not much corrected, but the patients still have these kind of symptoms, we have to go for the bifocals in those children. So next is refraction in hypermetropia. We don't have to fully correct a hypermetropic child if there is no convergence squint. And we should record all the accommodative amplitude, especially if in a routine checkup the patient child is or any patient is hypermetropic, we should consider to perform an NPC, a simple NPC or NPA. That's very simple. So we should do the accumulative, we should measure the accommodative amplitude in every patient, those who have hypermetropia. And we should perform the fogging. It's very important. I'm not going to explain detail. And refraction in astigmatism. We can correct the astigmatism in every children, those who are greater than 4 years, and they are very symptomatic. And also we should correct the oblique astigmatism fully, because oblique astigmatism is more prone to develop amblyopia. So in this case of oblique astigmatism, we have to correct the full amount of astigmatism. And we should record the keratometry value if the patient has greater than 3 diopter of keratometry or astigmatism. We have to record the keratometry in order to confirm whether it's corneal or not. So next is refraction in strabismus. Most of the refractive cause of the strabismus will be a high myopia, hypermetropic or myopic astigmatism. So cycloplegic refraction is very important in these cases, especially in strabismus and hyperopic patients. So suppose the patient is myopic and the child has an intermittent exotropia or a large angle exotropia, we can give the full correction. We can give the full cycloplegic correction or either a slight overcorrection. If it's improving the PSV of the patient, it's okay to slightly overcorrect the myopia of the patient. So next is a refraction in refractive accommodative esotropia. Refractive accommodative esotropia is a condition here which happens due to the over-accommodation with the patients who have high amount of hypermetropia. So here also fogging, in subjective refraction, fogging is very important, and also should advise a cycloplegia in every patient, those who have hypermetropia and accommodative esotropia. So here in some cases the patient will complain, the child will complain diplopia at a distance if it's esotropia is more at the distance. And here also there is a chance to develop, here in these cases it is actually occurring due to the over-accommodation of the patient. So then here esotropia will be higher when comparing to the distance esotropia. So here the AC barrier should be higher. So due to this problem, we have to fog, we have to give the full cycloplegic correction for this child. And also if it's not controlling the, it's not reducing the AC barrier ratio of the patient, we have to go for the bifocals in these children. And next important condition is accommodative spasm. This is very common since the pandemic. It's actually occurring due to the prolonged nerve work, and it's happening in accommodatively active patients. So sometimes it may stimulate conditions the patient has using the pilocarpine. So here their accommodation will be arrested at the near. It is happening due to the prolonged use of nerve work. So their accommodation will be arrested at near for a long time. So here the patient's first complaint will be blurring at the distance and also associated headaches, eye strains and difficulty while concentrating. So here we can see the PSV, possible PSV findings here. That is, there's a chance for occasional esotropia or esophoria in some patients, and while it's better to advise an orthoptic evaluation in such patients. If we do the orthoptic evaluation, we can find the reduced AF value. That will be a difficulty in clearing the plus lens, and also the reduced negative relative accommodation is very important, and difficulty with plus lenses. Normal NPC and NPA value will be normal here cases. And while refracting the patients, when we take the order of value, we will get a high myopic value. But while we doing the retinoscopy, we will also get a high myopia to hyperopic value. So here cycloplegic refraction is very important. Whether the patient is 30 plus or a child, we have to suggest a cycloplegic refraction in this kind of patients. Well, during the subjective refraction, if we check the unaided visual acuity of the patient, that would be fluctuating from the counting fingers to 6/9 or 6/12. That will be depending on the severity of the condition. And also the near visual acuity also will be varying, because the patient couldn't concentrate more at the near due to the excessive stimulation of the accommodating convergence. So the patient also, actually they will have a good near visual acuity, but it will be varying due to the hour strain. And here also the patient will eat up more minus while refracting the patients. And there also we can see an improvement in their visual acuity also. But post-dilatation, if we try to check the unaided visual acuity of the patient, we can see a definite improvement in their visual acuity. So how to manage this kind of patients? In a rare conditions, there is a chance to resolve the spasm at a first cycloplegia, but most of the cases will take time to resolve. So that's such conditions we have to give a cycloplegia along with the near ad. So first we can try hometropin. If it's not requiring, it's not improving the condition, we have to go for an atropine with a addition. So next important condition is subluxated lens. So subluxated lens is a condition. Here the lens will be partially displaced from the pupillar area. That would be varying. It may sometimes displaced from a large portions, or it may be partially. So here these conditions, we will get two type of refraction. One myopia, a high myopic refraction, and also a phakic refraction, that is a high plus refraction. So here the patient will complain of defective vision and also monocular diplopia due to these two kind of refraction. So here the refraction will be lenticular. We will get a high myopia or a high astigmatism, usually the lenticular. So how to manage these patients? We have to do both the phakic and refractive, phakic and aphakic refraction here. And subjective undilated refraction is very important in this case, because after the dilatation, the aphakic area will be more exposed. So the patient will not satisfied while correcting this aphakic correction, while we give the aphakic correction. So we have to do a perfect phakic refraction, that is undilated refraction, then we should correct the myopia properly in these cases. So early we used to correct the aphakic correction along with the atropine, but now we usually go for a surgery. So thank you.
And Vice Principal of Jubilee Mission Hospital to give a talk on spectacle dispensing.
Thanks for the chance. So after the subjective, objective and practical tips of refraction, finally the patient will ask, Madam, Sir, ശരിയാണ് ഇപ്പോൾ ഏത് കണ്ണട വാങ്ങണം, എവിടെ വാങ്ങണം, ഏത് ഫോക്കസ് വേണോ, സാധാ വേണോ, some lot of questions will be there. So my talk is mainly what is the spectacle choice available in the market. So I have no financial interest. So this talk is based on a book written by me and Dr. Krishnan, Refraction State of the Art, the 21st Century. So this talk is based on the textbook and is released a few years back in KSOS. So what are the eyeglasses available, or what are the frames and lenses available in the market? Just to go through that, I cannot have a detailed discussion, but I will just see what is happening in the market. So now every patient has a unique lifestyle. Susmi has already revealed that. Spectacle dispensing is very mandatory now. Everybody have based on their self-image, their occupation, their leisure activities, personal values. So based on that, you have to select the spectacle. So that's very important. So as an optometrist or as a doctor, you have to have a vital role here, because you are an expert to expert the best spectacle for the patient. So better visual experience, the patient will be happy. So he will come back again. So that's the best reward you can get. So spectacle varieties, as you know, it can be single vision, it can be reading glasses, it can be bifocal or multifocal or progressive or sunglasses, different variety of sunglasses with power and without power, then occasional spectacles, lot of things are available. And the occasional use are half-eye reading glasses, then safety spectacles, swimming goggles, sports glasses, driving mask, computer special glasses, welding glass, etc. is available. And the frame variety is the half-eye reading, that's a normal reading glass, then full rim like this, then three-piece or rimless, then half rim or supra frame, then special type clip-on lenses. All frames are available. The frame material, time-old material was metal alloy, but the corrosion, that's a problem. Then shell frame, so the younger generation now go for shell with multi-color and mainly black color they are liking. And stainless steel and aluminum is now out of market. And the market now is by titanium. Those who can afford, or the adult people, they go for a titanium, more than 40 age. Gold frame was a prestige issue, free visual nowadays. Nobody can afford a gold frame. And the lens varieties can be single vision for myopia, hypermetropia, or can be bifocal, crypto-bifocal where the upper part is round, or can be D-bifocal where the upper part is flat. Trifocal was in the market, now it is out of market because of the multifocal or progressive glasses. Then lens material, the time-old material was round glass, sada glass, but the only problem it can break and then there is no scratch, no possibility. But the thyroid putti ball and more weight also, that's the only problem. And then came the CR39 or Columbia resin 39, that is a research product from America, that's the best class. Scratching is the problem, so you look at a scratch resistance coating. And it can break. If you are fitting for a three-piece for a rimless frame, when you make a holes, it can crack. That's the problem with the CR39. So then came the polycarbonate, that's unbreakable, impact resistance, very lightweight, UV protector. And it is called a bulletproof plastic lenses for the aeroplane and bulletproof car it is used. So that's ideal for children. Then photochromic lenses, that means you can change the color. So when you expose to sunlight, outside it will be dark in color. So because of the presence of silver highlight crystals in the lens, and when you expose to UV radiation, it will change the color. So you give a protection to UVA and UVB. So it is usually called a variable tint glass or day and night glasses. And the new name is for CR39, it is called a transition series of lens. So you can see the color is changing, depends upon the sunlight. So this is a CR39 ordinary glasses. So you can see, so CR39. So the company people say it will not break, but you can see ordinary fiber glass, it is breaking when 500 gram is dropped from a height of 75 inches. So what is the solution? You should have a polycarbonate or trilogy lens. The same 500 grams weight is fallen from a 75 inch. It is not breaking, so that means for children you should go for a polycarbonate lens. But high index lenses, the normal refractive index is less than 1.5. Here refractive index is 1.6 or 1.7. So that will reduce the lens thickness like this, and your appearance also, cosmetic appearance also will be better with a high index lens, especially for high myopia. So it will, and S-free high index is available, that will reduce aberrations, that is ideal for children. It will be 46% thinner and lighter than ordinary CR39. And there is a lot of lens treatment like tinting, ultraviolet coating, anti-reflective coating, scratch resisting coating, transition of day and night, all varieties are available. So why should I have all this protection? Because there is atmosphere, the sunlight is coming, and the ozone level will prevent almost all the ultraviolet up to UVC. And the ultraviolet B can reach up to the cornea, can produce pterygium or conjunctival opacities. But UVA can reach up to lens, that's supposed to be reasonable cataract. So if you want to prevent cataract, pterygium, etc., you should have a protection in your spectacle. So this is a base lens, and over that base lens you can have a hard coating, then you can have a ultraviolet coating, then you have a anti-reflection coating of 7 layers of Vigior, and finally you can have a hydrophobic coating. So what is the significance of tinting? Tinting is very cheap, only 200-300 rupees. Different colors are available, but it will last only for 1 year or 1.5 years only. The pigments used is melanin, sp2, brown pigments, etc. All these colors are available for tinting. So at only choice you can have tinting that is comparatively cheaper. But actually you should have a scratch resistant coating, especially for CR39. So it is always scratch resistant, not a scratch proof, but it gives some protection for the CR39. And you have anti-reflection coating because 99.6% of light will be passed through that the lens. If you have a coating, only 0.4 will be reflector, so it will be helpful for driving and everything. Night driving, it will be very easy if you have an anti-reflection coating. Not only that, your appearance also, cosmetic appearance also will increase without, this is without coating and this is with coating, so that's a better of KSOS coating. What is smudging? When you have a touching over the spectacle, there will be oil, anatomyum, either lens, when you have a hydrophobic coating, that will prevent that also. So when you're rainy season, so the water molecules will be on your lens, so you can have a water resistant coating also. So in the COVID era, there is a problem with the fogging of the lens after mask and everything, or when you come out from the AC room or AC car outside, there will be fogging, or when you're enjoying tea also, there will be fogging. So to prevent that, you can have a optic fog coating also you can do. When you go to Himalaya or the hilly area, Mudar and everything, there's a glare, or beach area. Kozhikode also there's a beach is there, so when you go to the beach, glare is polar, so you have a choice is polarized lens you can use. And polarized lens is available as a single vision or single vision with the power, or progressive polarized lens is now available. Only thing, it will be little deep color always, it will not change the color. And for driving purpose, you have a photochromic polarized lens, that means that will change the color, depends upon the intensity of the light also, that's a 100% protection you will get. And sunglasses are available all for sports and games with all the power, without power, everything is available. So with the senior people, they can wear progressive lens also available for sports and games. And polarized 3D glasses available whenever you want to view a cinema or film or TV with 3D pictures like My Dear Kutichathan or Avatar or something like that. You can have a polarized 3D glass also available. And for spectacle for kids, ideally it should have it should be never be glass. It should be either polycarbonate, or ideally it should be at least CR39, and should have a S-free coating also. And for presbyopia, what is more is that you can have a separate glasses for distance and near, or you can have a bifocal glasses. Only problem you miss the intermediate area, and there will be a dividing line in between also, and that will reveal your age also. When you are using a bifocal lens, it will reveal that you are above 40 or presbyopic age. So solution is you should have a progressive lens, so you can have a distance, intermediate and near vision you get. This is a bifocal, so when you are watching the TV and newspaper, you may miss the T, and if you use a progressive lens, you can see the T given by your wife on the table, you can see that also. But the problem with the progressive lens, the fitting should be very correct. The fitting cross should become on the center of the pupil, and the optical center should come the lower margin of the pupil. And this is the area where the distance power is given, and this is the area where the near vision is given. And this is the shows what is the near vision power, that is 1.75 addition. And these two engraved circles should be permanently there. So when you make a line through these two engraved lines, it should pass through the lower margin of the pupil, then the fitting is correct. But when you go for a progressive lens, the frame size should be at least 34 millimeter, then only you get a full area. And the fitting height should be at least 18 millimeters, so it's a problem. So nowadays people like a small frame, so there is a new progressive lens came with a fitting height of 14 or 60 millimeter also. And the problem with the progressive lens is that all this blue area will be glare, or distortion will be there, or the white area will be visible. More distant and more near area, intermediate area is very narrow, that is a progressive lens problem. So different designs are available, like a hard design, soft design, symmetric, asymmetric, depends upon your occupation. And this, as I told you, bogus lens, when you are driving with a bogus lens, you may miss the traffic signal, or in these football games and everything, you may miss the goal gained by Messi and everything. So that's a problem with the bogus glass. So if you have an advanced digital bogus lens, you will not miss the goal or will not miss the traffic signal. So of course it will be a little more expensive. And for selection of the frame also, a lot of software is available that called iPoint. So with this software, you can have a camera, you can take multiple photos with multiple frames, and you can decide which frame should be selected. And it will select for the which glass will be selected, and it will also help for contact lens fitting and everything. And there is a lot of browsers available for online purchase of lens and frames and everything. Lenscart is another example. You can choose your lens and frame from the online purchase also. And the fitting of the lens, lot of features are there. There is the vector restrictions, the band object deal, the pupillary alignment, IPD measurement, base curve selection, optic center marking, everything should be correct. Then only the fitting should be correct. And to help you, there is a software available that will be Office that they can incorporate into the computer and put the patient in front of the computer and everything. And the software will measure the face anatomy, the wrap angle, the pandoscopic tilt, the pupillary distance, the backward distance, everything the computer will measure. And the dummy lens of a frame, you can mark all these things, then you put in the computer. So that will help for the exact fitting, especially for progressive lenses. And this computer you can transfer into the fitting machine with the grinding machine or fitting machine. The machine will do the grinding, the etching and the making groove, holes, etc. And only finally your job is only to put the screw on the frame, that's only. And there's for computer use, there's a lot of choices available. A normal vision spectacle, computer reading glass, occupational progressive, that's the ideal thing you have to use. What is occupational progressive lens? It is called a multifocal S-free progressive design for both near and intermediate area. So it is a special progressive lens. And in this normal progressive, there is more area for distance and near and very little area for intermediate area. This occupational progressive, more areas for intermediate and near. And all the international brands like CSOS, Panorama, SLR, everything is available. And those cannot afford for this progressive occupational progressive lens. There is a clip-on lenses, clip-on lenses. To your normal frame, you can add clip-on lenses, so that can be used for near or computer use. Those who are not required also have a small glass with a 0.25 diopter power with a photochromic UV protected glass. You can use normal people with those who are IT people. So that will protect you from ultraviolet radiation of the computer also. Plus 0.25 give a little relaxation of the accommodation also. Anybody can use this 0.25 glass with a separate UV protected glass. So the choice for computer use, you can have a simple reading glass only 150 rupees, or bifocal glass with 1000 rupees, or progressive glass with 3000 to 5000 rupees, or occupational progressive lens from 5000 to 10,000 rupees. So the new trends are coming in the frame and lens and everything. As I told you, the children like shell with multicolor, and the adult more than 40-50 like titanium frames. The shape and style is changing. And the brand, all the brands, international brands are available. The price can vary from 1,000 to 1 lakh rupees. Optimal and Surplus Indian brands frames. And the sunglasses, there are multiple choices are available with the color, shapes, color. Everything is changing with a different price tag also. The price can be 700 rupees to 50,000 rupees. Sunglasses are available in the market, original as well as duplicate. And the lens brands, no lens is manufactured in India. All the blank is coming from outside, and the SLR and SLR is available in India easily. But all the SLR, Corning, Calcis, Kodak, everything is available. Of course, original and duplicate is coming from China and Korea. Duplicate is also coming. And those driving, the craze of driving motorbike and everything, you want to listen to the music also. There's a sunglass fitted with iPod or Bluetooth facility or Wi-Fi. You can connect with the mobile. You can enjoy. There's a speaker also, so the police will not catch you. You can enjoy music while driving. That's also available. And those who cannot afford a flat screen or the TV and everything, there's a special glass we can wear with this adjustment. You can wear plasma effect or flat screen with the ordinary TV. You can have the special glasses. And those who have a habit of sleeping in the class, especially in the morning or afternoon, there's a spectacle you can wear. There's a sensor is there when you bend your head or when you close your eyes, there will be vibration in your ear, so it will wake up you. That spectacle is also available. There's also a spectacle available with the scan your skin and everything, which will help you to see the deeper veins or arteries, etc. That will help with the nurses or doctors to take the vein, etc. You can penetrate the skin also. And a lot of glasses are now available. Google glasses with internet connection, you can be connected to the mobile with Wi-Fi or Bluetooth and everything. You can enjoy your music as well as message or WhatsApp, etc. With this spectacle, a lot of research is going on. New Google Glass will come in the future. And my final conclusion advice is that spectacles are very personal to every individual. Wide choices are available in the frame and lens. The selection depends upon the age, lifestyle, occupation, visual needs, taste and budget. Budget means your pocket thickness. How much money you want to spend. From 1,000 rupees to 50,000 rupees you can spend for a spectacle. And the special lens designs, coating, tinting gives good result. At least you should have a UV protection and anti-glare protection. So and reflection coating should be essential for your spectacle. And use only quality or branded lens only. Don't go for a duplicate. So whenever you go for a spectacle or frame, ask the optical shop fellow for the guarantee card or the brand guarantee card. That will ensure that it is original lens. And as a technician or doctor, you have a vital role here because you are giving the prescription. The prescription of the lens should be correct. So that's the most important thing. Because you are getting only, doctor may be getting only 100 or 200 rupees and optical shop fellow is getting 100% profit, or that means 1,000 to 5,000 rupees. And all the blame you will have to bear. So and our ultimate aim is wearer should see well and look good also. So finally, see better, look better, feel better and live better. So that's our motto. So I think you can follow this. So thank you very much. You can, this is my email. If any doubt, you can contact me. Okay, thank you very much.
Excellent talk, sir. I'm Dr. Kudlu from Udupi. The one more glasses actually come with two different brands from Zeiss and Essilor also. That is a myopic progression control glasses. So they have made something sort of for a kids different set of progresses so that whatever the elongation of the eyeball, that will prevent according to them. I think they just came in 1 month before. Further study is required. If that goes, I think that is also one of the eye opener children.
So we move on to the